MedBix webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Hey, welcome to the MedBix webcast. This is Ramana Anamaraju. I'm the host of the MedBix webcast. We have a really good program. It's an international kind of thing today. A guest is joining from South Africa. Think about that. All the way from South Africa, early morning, 3 o'clock in the morning, she's joining with us. Then after that, I'm going to present a topic on, actually there's a connection with Africa. Secrets to the plastic surgery. There is a deep connection to the African connection. I'm going to tell you that is surprising to you, all of you. There is a secret number to do plastic surgery. A lot of plastic surgeons follow that. So it is going to be exciting. The thing is that, let me tell you why I do all the international. I want to get a perspective from different people. What's going on in healthcare? Health is a human right. Health is a human problem. And then we need to listen to everybody in the world. It's not just Americans, not Canadians, not just one country, India. We have to listen to everybody in the world and solve this problem. We have a big problem. It's a huge Satan in front of us. That is a cancer. We need to solve that as a humanity together. And it is such an important thing. We need to solve cancer problem. We need a cancer advocacy is such a central theme for all of that. Salome Meyer is going to join with us from South Africa, Cape Town, South Africa, where actually Christian Bernard, the heart transplant surgeon, first transplant surgeon was there. The first heart transplant was done in the Cape Town hospital. That's where she is going to join. She is a true fierce advocate for the cancer. Salome Meyer, joining from South Africa, Cape Town. Welcome, Salome. Thank you for joining second time. Love to have you.
Good evening, Ramana, and to all your viewers, wherever they are. Good evening.
Thank you for joining early morning, 3 o'clock in the morning. But thank you for. Tell me something about your background just until now, the journey of you. How did you end up in the advocacy side?
Well, my journey is that I started as an advisor in cancer or in community development more, and that was about 30 years ago. Before that, I trained as a medical social worker and I worked in community development. But I then decided that I need, after the death of my friend, I decided that I need to devote my life basically to cancer, and I became an advisor in an advisory capacity for many years. And then from there on, I became an advocate, advocating for cancer policies, for cancer registration in South Africa. And then very much later, I then became an activist. And today I then say I have now graduated with 3 A's from being an advisor to an advocate, now an activist, activating for equitable cancer care in South Africa, and have been doing this since 2016. And can say that we are slowly making inroads in the South African community to unite voices and to basically bring to the attention of people that cancer is also a basic right that people have.
Salome, if I remember that there is I saw one of your articles that is saying about that 85,000 people dead because of the inflicted with the cancer, and then so they have a lot of waiting list in some of the hospitals with the outdated. South Africa is one of the most advanced country in Africa. they have the resources, they have the money. So these are not available for access to the people. That how come they, one of the most advanced country in Africa, don't have the resources like even other countries in Africa? That what is the reason you think? Well, the waiting list, there is a protest of the waiting list. Saw that. So tell us a little bit about that.
So if we just look at South Africa as a country, yes, and I think that is where lots of people do think, yes, we are one of the richest countries in Africa. And I suppose it may be from, from a fiscal point of perspective, maybe yes. But if we go back into who we really are, we are one of the most inequitable countries globally. 86% of the population access public health care. 86%. 14% of the public, of the citizens in this country, access the private sector. The private sector is then funded through your medical schemes. But if we look at the healthcare personnel and the equipment and the hospitals that has to service the 86% of the population, and I'm now talking about cancer care, then only 20% of the healthcare professionals, and that's also including then equipment, service that 86% of the population. So that is what happens within the public sector. So yes, it is a system that was inherited, and in terms of, but you can also then argue that for the last 30 years, what has been done? So a lot has been done in terms of health care, but on the other hand, we can also say that we've got a healthcare system that is now failing the public sector. And particularly with regards to cancer care, and in Gauteng, we have more than 3,000 patients that have been on a waiting list for radiation oncology, some of them for more than 3 years. And that, in essence, is what we say is a gross violation of a basic human right. And last year, so we've been protesting about it. And last year, the Treasury Department of that specific province allocated 784 million rand. Now, for us, that's a lot of money, for specifically the services to outsource, meaning outsourcing from the public sector to the private sector where there is capacity to outsource that radiation treatment, specifically then for those patients. And now, 13 months later, not one single patient has yet had any treatment. And that's why we took to the streets. And we just said, enough is now enough. We want answers.
Along those lines, Salome, I checked a little bit about. I used to sell PET CT scans. So you only in entire Africa is 63 PET scans, PET CT, where you can detect the cancer. Actually, can detect. That's a gold standard. In the United States, we have a 3,500 for 200 million people. For 1.5 billion entire African continent, only 63 PET CT scans. That's a really horrible number to even give access to diagnose any kind of cancers.
That's correct. We if we actually do go into the number of equipment that you require for any diagnosis with regards to cancer, you will see that the majority of the equipment is actually vested within the private sector. So then if you then start looking at Africa per se, yes, South Africa has got quite a lot of the equipment with regards to cancer diagnosis for Africa. But what happens also is there's a lot of our fellow African countries, people come to South Africa for their diagnosis. They then have to access, they can't access the public sector. They have to access the private sector, and they pay premium price because the cost of oncology services in the private sector is very high.
So
And
why
what we
don't they take that? Yeah, why don't they take that money and put in the public sector, that the premium price they're charging for these the Africans? It's a lot of mismanagement. Must be some kind of a mismanagement or some organizational structures. Maybe there is no vision. Something is missing there that I don't understand.
So there is now the movement by government, and has been for the last couple of years, to implement a national health insurance system in this country. But that the bill has been passed in Parliament, but the bill has not been signed by the
Okay.
president. And that is the key to everything, because literally, once that bill gets signed, then we can start with the implementation of a national health insurance system. Now, the people, somebody asked me yesterday in an interview, what's my perspective? And I literally say, from a cancer perspective, if I can take the president a pen to sign, I will do so. Because I know that with an NHI, we will have a far better equitable cancer system in this country than what we currently have. But what is going to be difficult is to fix the health system, because we currently have a failing health system, failing for the majority of the population. 14% of the population have got excellent services, and that 14% is in fact very scared that they're going to lose everything. But you've got to balance the scales somewhere along the line.
That is not a real game, that if somebody loses, somebody wins in the healthcare. Everybody should get equitable access to the care. It's possible to get equitable access to the care. You know, South Africa, you tell me a little bit about it. I don't understand why South Africa, among all, even though this is the richest, one of the richest countries, you mentioned a little bit about the disparities, but one of the highest incidence of cancer in South Africa than other African countries. What is the reason you think?
So cancer has always had, and I had a high incidence in this country, but I also want to say that our real figures or incidence figures for cancer is, in fact, we don't know what it is. So if we look at this, there's about a 40% underreporting of cancer in the country, and this is due to many reasons. First of all, cancer being diagnosed at a late stage. So many people actually don't get diagnosed. It is just, they are in rural communities that don't get diagnosed. Then we also have the situation that the private sector don't necessarily submit their data to the National Cancer Registry. Our cancer registry is only a pathology-based register. So that's another reason, because not all cancers are diagnosed through pathology. There's other ways of diagnosing cancer as well. So it is indeed an increasing burden of disease. And we do know that it is going to increase drastically in the next 10 years. And one of the main reasons and contributing factors to that is the fact that we have got a very high HIV burden. And with the success rate that you have had over the last 20 years now with ARV treatments, we now have a population of people that will live longer. And because they're living longer and because of their compromised immune systems, they now are facing challenging cancers, such as, for instance, your non-Hodgkin's lymphomas that are also associated with HIV. And that's going to increase drastically. We also have cervical cancer. So
Yes,
and that in essence is one of the most, or it is the most preventable cancer
correct.
because there is a vaccine. And those are the kind of issues that we have to grapple with. Then the other one that is extremely high in Africa, in South Africa, but I also believe it is also high in the United States, is prostate cancer. Now, that's the one cancer that nobody wants to talk about because we just don't talk to men. We don't talk about anything that's below the belts. And in an African environment, that is a definite no-no. You don't talk about that. So prostate cancer is, for me, one of the issues that really I think is going to explode in Africa if we don't start paying attention to the increase of prostate cancer, and that it is in fact something, again, it is a cancer that is very treatable. If we start looking at your hormonal cancers, breast cancer, again, early stage disease, manageable. The moment that it becomes a late stage disease, you can't, then it becomes difficult to manage.
I don't know about the United States, the ignoring about prostate cancer. They take care of the men very well in this country. That is the one thing they pay a lot of attention. But just let us talk about the cervical cancer, which is a preventable here. And then one of the highest incidents in Africa is South Africa is the cervical cancer. So what is the vaccines can prevent, as you said. So how can what is the problem with the vaccine supplying to the young girls? You can prevent them. I don't know how many doses they give, but how many doses they give, but one or two doses. I don't know, but exactly, is it possible that they you can what is the problem of giving vaccines to the age of 9 to all the way to the first sexual experience with the young woman?
So South Africa currently, and for the last 10 years now, we've had a very successful vaccination program where we vaccinate our school-going girls. That's between the age of 9 and 15. That's the cohort that you vaccinate. And we currently vaccinating with the bivalent vaccine. And therefore, those girls need to have 2 doses of the vaccine. However, WHO has already come out and said that the non-valent vaccine is actually only 1 dose is required. So South Africa is now looking at with how we can transition from the bivalent to the non-valent. However, we need to say that there is a supply problem with the non-valent vaccine in terms of from a manufacturing perspective and then a supply perspective. So those are the kind of issues that have to be sorted out in Africa. And South Africa is not Gavi eligible. And because it's not Gavi eligible, it means that we've got to pay top dollar for the vaccine.
Let us explain to the our audience. Gavi is that's a fund. Actually, George Bush allocated $15 billion to the Gavi fund, right? That's a huge fund available for the treatment of the HIV. Is that right?
Yes, so no, for Gavi is for all your vaccines. So if you
All your vaccines, okay.
all vaccines, so Gavi only focuses on vaccines. So
Okay.
that would be your polio vaccine. That would
Okay.
be in future in future we're talking about your TB vaccine. You're talking about your malaria vaccine. And now with COVID, it was your COVID vaccine. You're talking about your BCG, all of those vaccines. That is what Gavi provides, but for Gavi eligible countries. And then if we look at what is a Gavi eligible country, it's very much your low income countries. And that is where the World Bank classifies you as a low income country below, I think it's $1,500,
Yeah.
if I'm not mistaken. So those are the countries that is Gavi eligible in terms of funding. And then there are different models in terms of countries that have got a little bit higher on whether they do get support or whether they can actually get some form of, I want to say, subsidization from UNICEF in terms of the vaccines. But if we come back to South Africa isn't eligible for that. Now, when we look at the cost then of vaccinating your total population, meaning your girl population, you're talking about a lot of money, and especially if you have to talk about two vaccines that you've got to provide. Now, therefore, it will be more affordable for us to provide the bivalent vaccine, which is, I want to say, fractionally more than the bivalent vaccine. The nonavalent is fractionally more than the bivalent vaccine. So it will be more affordable for us to provide that for one dose only. But then comes the next uh, um, proviso on that. If you are HIV positive, you've got to have two doses. So with a country where we have a high HIV rate, we possibly will still spend a lot of money on our HPV vaccination. We currently are also then starting to look at also including girls in private schools. So only public school girls are now being vaccinated. And now we are looking at a strategy to expand that to our private schools as well.
So, Salome, if I do understand, is the HIV fund that United States World Health Organization provided, PEPFAR, for example, is one of the Bill Dr. Bill Frist is one of the pioneers is one of the senators from Tennessee, provided a huge amount of money to the PEPFAR, which is the I don't know the abbreviation, I don't remember the abbreviation, but it is money towards the AIDS in Africa. Is that are you not eligible for that? If I
So South Africa do benefit from PEPFAR funding, and most of the funding, I want to say, that is available within the HIV TB space. We also get a lot of money from Global Fund
Okay.
for HIV prevention and so. But what we do know is that HIV until such a time that there isn't a vaccine for HIV, we're going to have HIV with us. And it again comes back to the whole aspect of education. And that is similarly what we have to do with HPV. We need to start educating our younger generation about the importance of HPV vaccination, whether it's a boy or a girl, in countries that can afford, such as America, who can afford the vaccination for boys as well, that is important. But then we also need to educate our younger generation about sexuality and because it is a sexually transmitted infection, a virus that is sexually transmitted. And if we then start looking, it's not only just cervical cancer. There's 6 cancers that are caused by HPV. And we need to start looking at that as well in terms of how is that busy increasing. And I actually am very listened to a program not so long ago, about 2 months ago, from the United States about the HPV awareness programs that are happening in the United States, and I think we can take a leaf out of the from the United States and start implementing it here.
there is a overlap between the cervical cancer and HIV. Some of them are HPV, HIV. There is a overlap. A lot of girls get more prone to cervical cancer with HIV, right? So I think, can you use that funds for the global fund to utilize for this for the cervical cancer patients?
So the you have to, what we have done specifically is we have started, and the global fund has allowed that, have started
Mm.
motivating for the for HPV screening
Yes.
of your vulnerable populations as a pilot program. So we now are currently looking at the pilot program in 5 districts of HPV screening for in your vulnerable populations, and that would be your HIV populations, the young girls, as well as your sex workers. So that correlation happens there. So there is a bit of cross funding that comes through that. Yeah.
I'm a man, so I may not know. Is it a pap smear test you do for the HPV, or is there any other test they do?
There is, so in South Africa we have got a pap smear test.
Yeah.
That is how we've been testing for cervical cancer all the years. So we've got a very ingrained pap smear testing program. However, which then means that you still have to have a, a, a smear taken by, or a sample taken by a trained health practitioner, whether it be a registered nurse or a gynecologist. And that can then go into what they call a liquid-based
Yeah.
cytology thing, and that can go, and then you have the opportunity then to do both these. If it was a pap smear, you can then still do an HPV screen as well as the pap smear, and then see your DNA testing that will give you the specifics, and pap smear will also then, confirm that. So that's what we use at the moment. I do know, and that is something that we hope we can roll out. I want to say in Africa, I am aware of a rapid test that is available. It is a rapid test, if I'm not mistaken, that was developed in China, but it is an American firm, that is a company that is have got the rights of the rapid test. And if that rapid test is available and can be validated, and even with the WHO, World Health Organization, if they can pre-qualify that test, then we have, as far as I'm concerned, a game changer.
Yeah.
Because your concern always is that when you do a pap smear, and even then for a HPV DNA test, you've still got to send that test
Again.
away. It takes you anything from, I want to say, from 48 hours
Yeah.
to a couple of days to get the results back,
Yeah.
which means that the women have to come back to the clinic. And that's where things get lost into
Correct.
translation.
The
If we can
logics. Yeah. Go ahead.
a rapid test where you can, at point of care, test the woman and then conclusively say, yes, there is HPV present, you then can triage that woman for a colposcope, as well as then take it further with a thermal ablation. So there are options for treatment immediately.
So
And
it's
that's the
very good. There's a good thing you're going in a vaccination, and you have some plan at least for screening in South Africa. Your massive mass screening you want to do for the pap smear and all, or your HPV vaccine, HPV you want to do, and maybe you are going through some crisis on the supply chain side. Let us talk about Africa in general, Salome. Which countries really doing well, which countries are not doing well in the screening of this cervical, particularly young woman cervical cancer, because I'm focusing today on more of a cervical cancer side, because that is a preventable, that is a that is absolutely preventable, and vaccines work very well with that. So let us talk about the other countries, how they're doing. Just if you have some knowledge about Tanzania, Uganda, just give us a little bit background on that.
So the countries that are really setting the example would be Kenya as well as Rwanda. Rwanda, I think, is really the country to follow in terms of what they are doing and how they are implementing very much an integrated approach from vaccination right through to screening and treatment, making sure that if a woman is then screened positively for precancer, that she is treated, but as well as then for later stage disease, that treatment centers are now becoming available, and the same with the training of healthcare professionals as well as palliative care. So they really are looking at an integrated approach. Kenya is the other country where they are also far advanced in terms of an integrated approach. The other countries that are slowly, and I say slowly, coming on board in terms of HPV vaccination would be like Nigeria. I know that they are also starting to do their program. There are other countries that also are doing. Uganda is also another one that we can mention, as well as Malawi. So the countries are slowly coming on board with the elimination strategy. I am part of an organization called ACHA, African Cervical Health Alliance. And we are 16 African countries with 22 civil society organizations that are working in terms of promoting and advocating for the elimination of cervical cancer. That means that we are reaching out to government to improve the cervical cancer in many of these countries. So I did say to you that in South Africa, we've got a cytology-based pap smear screening now for years. But in many of your African countries, you've never had that, because cytology means that you've got to have a very good laboratory system in place. So many of the African countries have used visual inspection, and therefore the move from visual inspection to HPV testing is something that many of the countries are now starting to invest in for their screening. And that is also very exciting, that they immediately jumping in and doing HPV screening.
It was amazing what he said just now. Rwanda, a few years ago, is the center of a genocide, and then you're saying that's one of the most advanced country in the testing of cervical cancer. I'm so glad to hear that. People can change, the world can change. This is a beautiful example of that.
I think we need to say, that with the Rwandese, that you have political will. And because of the political will, there is just an amazing willingness within the country to work together and to collaborate. And I've had the privilege of visiting Rwanda. And for me, it's really a country where you can just look at them and say, this is amazing. I mean, just as another example, plastic is not even allowed into Malawi, into Rwanda.
Hmm.
So
What a transformation it is.
a total transformation. So
Yeah.
it can happen because there's political will. And therefore, because there's political will, they are willing to direct money, funding, and resources towards the needs of the country. And I think that is quite important.
I interviewed a doctor, Dr. Robert Pearl. He says the leadership is such a vital importance for the healthcare changes. I agree no more about that. That is a beautiful, beautiful example. Salome, one more thing I wanted to ask you. The South Africa could take a leadership in the role of, they have excellent doctors. Universities are one of the best in the world. You have the art transplant I mentioned. So what they are doing for that themselves are not taking care of themselves. Now it's a problem for even providing a leadership to the other African countries. So that is where the things come. Outside people, it's very hard for them to come down and understand African culture. Do you have some comments on that?
I think that we've come a long way. I want to say in terms of cancer care. Cancer care, for a very long time was vested mainly within the white population, and it's slowly changing. We're starting to see the demographics of the healthcare professionals is now also changing to reflect the society that South Africa is. And that in itself is a major change. So, and it's happened slowly. So, we hope that in the next couple of years, that it will also be more equitable from that aspect. But as I said, many of our or 80% of the healthcare cancer professionals actually work within the private sector.
Salome, people like you are a voice for voiceless people. Your advocacy is such a critical importance. That is a true advocacy. What you do, I nothing but admiration. But I'm going to tell you a story about Africa. Interesting story, Africa, and then after that, I come back and ask you about your organization, how anybody can help and participate. Let me present it. You and me are going to watch. You can jump in anytime. You have a lot of knowledge than me, a lot of ways. That is Salome Meyer from South Africa, Cape Town. Cape Town, South Africa. That I'm going to talk about. I'm going to bring both of us in the side. Okay, now we're going to watch together. So this is the South Africa. So it's one of the most advanced countries. It is really doing good advocacy. They went through apartheid and they came back and really doing. And then she's giving a true transformation country is Rwanda. I was surprised to hear that. Um, that is information we need to learn. PEPFAR and all those. Dr. Bilfrist, if you're watching, PEPFAR is working. But anyway, let's go into the fun side a little bit. I'm going to give a. This is a beauty pageant happened in South Korea. It is a 2015. In this a small beauty pageant in the Korean in 2015. All the girls looked exactly similar. It's a Korean press said that it's not like a outsider like Indian saying that all the Chinese look the same. Actually, Korean press said that they all look eerily similar. That's what Korean press said that. It is surprising to the judges. Why they all look similar. What they found out is that they all went into the same plastic surgeon, Ganganam ratio plastic surgery. They all went there and they wanted to get the same thing, so they all look the same. That's the golden ratio, the Ganganam golden ratio plastic surgery they went to. So that is a problem they found. Is a plastic surgery capital of the world is South Korea. You know, not South Africa, South Korea. So actually, what is the golden ratio? Then why did you put that name? Golden ratio is it came from the Greek sculptor Phidias. He's a god. You say that is if you measure the length, the height is up to from head to the novel. It is a 1.6. It's a 1 meter or 1 point. Then 1.6. That is a 3 meters and 3.6 is a tall guy, 6.6. So it is like that ratio has to be maintained. That is a golden ratio. It maintained the three up to the novel is 3 feet and up to that 3.6. That's what the golden ratio they say. Let me explain a little bit about golden ratio a little bit more. It is the story. So beauty defined as a luscious lips, if you want to get a beautiful lips, they say upper lip has to be if it's a 1 centimeter in the lower, the top lip or the upper lip, the lower lip is 1.6, the width of that. That is the golden ratio. That is a maintained, that is called a golden ratio. A lot of plastic surgeons follow that. That is the that's why you put a golden ratio. So somewhat beauty is defined. Eyes, for example, same thing, golden ratio, the eyebrows, the distance between the eyebrows, and all those things, and the nose, all of them are following some kind of a golden ratio, the ratio between the length and the secondary part of it. So the golden ratio became a standard for the plastic surgery in a lot of countries. So what happened is, this is a where this all AI designed recently. AI designed a golden ratio complete human body. Who has that? Do you know who has the perfect body? Not me, but I tell you who is that. Helen Mirren, actress Helen Mirren. They found out she has the perfect body for the AI defined perfect golden ratio body in everywhere. She has a proportional body on the world. I don't know how they got all the measurements for her, but they got it. So they declared she is one of the AI defined best perfect body for the golden ratio. But the story actually began in it's actually 1100. The story began of the golden ratio. The mystery of the golden ratio starts from the leaning tower of Pisa in Italy. You know, is a it was it is actually year 1100 AD. That is where that Leonardo Pisa was born. Is 1170, was born in 1170 in the Leonardo Pisa in the Leaning Tower. So he was is a son of a naval merchant. His father is a naval merchant. He's a before Marco Polo. There is another Italian explorer, that is a Marco Polo. But the Leonardo Pisa is actually, they called him later on Fibonacci. I don't know why they call him Fibonacci, but they got the name of Fibonacci. That he was long before Marco Polo actually. So he was naval son of a naval merchant. He was going to, where they going, from from Italy to Africa, Sardinia, Italy to Annaba in the port in the Algeria. They're traveling and selling. They're doing the naval merchants. They're trading. They do a lot of trading. So he was accompanying his father on these trips to Africa, Annaba port, a naval port. So he was in 1100. Think about that. It's 200 miles. The distance between the Sardinia and the Annaba is a 200-mile sea coast, sea that you have to travel, go across. So what they found is that what they're buying, the Italians are selling silk, they're selling wine, and then they're trading wine and silk, and they're getting gold and spices. Where they're getting the gold and spices in Africa? These merchants, African merchants, going to India and picking up the spices and gold from India and selling them there, became a trading post there. So during this time, he's been going back and forth along with his father, the Fibonacci is coming with his father and doing this trading with Africans. That's a big trade. So, but what he was surprised is, he was seeing a counting. They're doing, Africans are different, doing a different counting. He was saw Roman numerals are 1, 2, 3. You see that Roman numerals, that's a very, very popular in Italy. That is what the mathematics of the Italy is. But on the right hand side, their Africans are following a different, and there is a one number they didn't. It's called a zero. Is there? That surprised him. What is that zero doing there? There is no zero concept in the Roman numerals. So the Fibonacci was a very curious young man. He was curious about it. So actually, he found out, after investigating, he found out these are Hindu numerals. They are Arabs are importing. They got it from India. The numerals from India. They're using Hindu numerals. They're using the Devanagari numerals. They call is a 0, 1, 2, 3. Is a single digits. If you see Roman numerals, much more complicated. If you see that the numbers go up, letters go up. It's a really complicated. When they have a 99,000, it's a really big number in the Roman numerals. So Indians are using the Arabs are using Indian numerals. That's what surprising them. He surprised. He saw that Fibonacci saw that, and what he did was he was shocked to see something that zero there. But zero came from India. Is a 6th century base 10 system. The Brahmagupta is one of the mathematicians of the 6th century. He published it. He was also using the place system. If you put a zero in right after one is 10, if you have two zeros to 100, as like a place system, it is a value increases by the place of zero itself. So India was using in 6th century. In fact, that is stunning. That is what the zero came from. So actually, zero is actually recorded zero, even though Mayans and the Babylonians used it, but India recorded the first one on the temple, on the Gwalior temple, as actually you can see the picture on the right side. They use it as Sunya. It's called a Sunya. It's a zero. They use it. That is the first in introduction of mathematics, zero in mathematics. That is that is a stunning to the Fibonacci. Fibonacci was really good in math, and he went back to Italy, and then he wrote a book, Liber Abbasi, a book of calculations. It is in this book. He mentions Modo Sundaram, is a method of Indians. He mentions about the place system and zeros. That is the first Western mathematics book he wrote. Fibonacci gave that book. The first Western mathematics book is of the Hindu numerals. Modus Sundaram introduces the place system, place value with a zero. That is just that changes the entire world. So Fibonacci sequence is adding. Then Fibonacci was very popular about is one of the sequences. If you take all the numbers 0 to 0, 1, 2, 3, if you add a previous two numbers, 1 plus 1 is 2, 2 plus 3 is 5, 5 plus 8 is 13. If you add a back numbers, that he created a sequence. That's called a Fibonacci sequence. You're thinking, what is the big deal about it? Is it two numbers adding in the back, or is it looks trivial? But something nature find interesting. Nature followed that sequence. That is, all the petals you see followed the Fibonacci sequence. You don't see in between. All the petals, either 2, 3, 5, 8, 13. That's the petals are always arranged that way. You don't see in between. So the nature allowed this following the Fibonacci sequence for very strange reasons. We don't understand 100% why, but it is following the Fibonacci sequence, the nature itself. So the Fibonacci sequence, even the biology, if you see the knuckle to the wrist to the knuckle, our lengths, our biology followed in Fibonacci numbers in the distance between the wrist and the knuckle to the fingertip. They're all Fibonacci sequence, 8, 13. You see that Fibonacci follows the Fibonacci sequence in biology. So Fibonacci sequence is everywhere. Stunning it is. Even a stock market, they call Fibonacci retracement. It is called a stock market. They use, actually, there is the way they invest people, they use the Fibonacci software, the Fibonacci sequence software, in fact. So Fibonacci sequence ancestry, for example, you want to find out, if you want to go the first person in your family origins, if you can use a Fibonacci sequence, you can go all the way to the first person. How many generations ago you had a first person started from your gene pool? That is so you need they use a Fibonacci sequence to go to the back to the origins. Then, but the golden ratio of Fibonacci sequences is actually, I told you that the ratio to 1 to 1.6. If you take where is the golden ratio coming out? Golden ratio is coming out to the Fibonacci sequence. If you take two numbers after 8, you divide the previous number, is always 1.6. You take 34 by 21, 1.6. 55 by 34, 1.6. 89 by 55, 1.6. That is some nature found as something strange. Golden number. That is called a golden ratio. It exists everywhere in the nature. Spirals, universe, all of them follow golden ratio structure. That is where it came from, a Fibonacci sequence, golden ratio. They found out Fibonacci sequence hold that universal truth, that is the Fibonacci golden ratio. But beauty defined after golden ratio is, a lot of people now, the plastic surgeons follow this rule. Some of the plastic surgeons, they do the golden 1.16, eyes. I told you already about the Courtney Cox, one of the famous Hollywood actress, about the lips. So she did that. That's his well published story. So same thing with the, so they beauty defined through 1 to 1.6 ratio, that they follow, that the people can look good. That's what it's aesthetically looking good, following the golden ratio. That is a secret number. So the golden ratio is, you can do the entire face. That's what I did. So the entire face of the golden ratio is one of the she's Hadad, one of the, I think, a model. He has the perfect shape. That's what they said. But misguided in the beauty standards is not, you should not we should not do. Beauty is on the beholder, or the eyes of the beholder. Is not that they went to they did not ask for the golden ratio. What they did ask, all the South African, South Korean girls, they went there, they wanted to look like a one girl from a Hong Kong model, Charlene Choi. They wanted to look like her. So they all went to the same. They asked the same guy, do the same, looking same. So that's exactly, they all look the same, to the horror of the judges. So that is the problem: wrong math and misguided standards. But what is the, actually we can use Fibonacci sequence for good things, to help people, for advocacies that people like Salome doing, we can do. You can use a mathematics to Fibonacci gait analysis, sequence of the gait analysis. You can tell them in advance whether they have Parkinson disease. You don't need a MRI scans and CT scans. We cannot afford it in certain countries in Africa. Certain population cannot have access. You can eventually, the mathematics can help. Gait analysis, you can do the Parkinson disease, Alzheimer's. You can measure, by following the Fibonacci sequence, then you can diagnose Parkinson's and Alzheimer's in the future. It's a very a lot of research going on in this Fibonacci sequence area. Fibonacci sequence could be the future new biomarker. The reason is, if as normal divisions of the cells, the spread, cancer is a mutation and spread, right? So on the left side, the normal divisions are a progressive division. You see on the left side, that's healthy divisions of the cells. If it follows the Fibonacci, the divisions usually follow Fibonacci sequence. That means bad news. If you detect a Fibonacci sequence in the division side, that is a bad news right there. The viruses divide, or the mutation cells divide. They follow the Fibonacci sequence. That is indication for the cancer and tumor bad growth. So mathematics can reveal so many things. So that, but it's going to be biomarker in the future. If you want to detect a breast cancer, people don't have mammograms, and it's a very hard to get a mammogram. Even in the United States, a lot of access is a problem. But what they found out is, if you use a temperature patch and you find the temperature variation on the breast in different spots, the temperature variations can tell you through Fibonacci sequence that whether that is a malignant cancer, malignant or calcification, or simple benign, is, you can tell from that temperature variance from the Fibonacci sequence. Think about that, how mathematicians are helping indirectly without knowing all this expensive equipment. We can eventually, our humanity is going to the artificial intelligence. New mathematics can help. 1,000 years ago, who invented a Fibonacci sequence, can help us to detect a lot of diseases. That is the feature of um, the future of, so you don't need that expensive equipment. Eventually, people who cannot afford, they can use the disposable patches. She's talking about, Salome is talking about, the rapid testing. That's all. Throw it out in the get the temperatures. It is already transmitted to through the cell phones, and then they can detect whether there is a cancer or not. Can you believe that? That is a really mathematical. You don't need a traditional way of thinking. You can do revolutionary thinking, mathematics and physics. That's where they play a role nowadays. So I think mathematics can save lives. People like Fibonacci, young man who is interested in mathematics, who loved counting. He produced this kind of introduced the Western mathematics, is truly remarked from 1,000 years ago. We have that, we can take that one into the new idea and reducing the diagnosing and treatment of the diseases you can do. That is, thank you for all watching. Let me bring Salome back to the table. Salome, then let me. How are you? Yeah, what do you think, Salome?
That was fascinating. I didn't know any of that.
Thank you. That's what physics and mathematics I want to bring to the healthcare. So you can change the world. We can change the world. We can give a more access to the, as you said, the rapid testing. All these things you can solve through AI, artificial intelligence. I'm Silicon Valley. I'm in the center of Silicon Valley. We can provide these kind of things with the new artificial intelligence. We can give a more access to people, right?
Totally. Totally. It would be wonderful if we can actually just expand that. And I do know that in South Africa, we actually have got an artificial intelligence device that can detect breast cancer. That was developed here in South Africa, and it's busy. I think they're busy rolling it out in some of our provinces. Yeah.
That's the great news. So, Salome, let me ask you. I always admire you. You are representing everyone in the equity. You're talking about South African equity, health disparities, and you're a great true advocate for that. What kind of organization you work with, and how do they people can reach you if they need to reach you?
So I am with the Cancer Alliance, and the Cancer Alliance is a non-profit organization. So we do take funding from any, I want to say, individuals, or even any broader organizations or companies that would want to sponsor the work that we do. We're very particular about the fact that we do not take money from pharma. And that's just because we say that we want to stay objective, in terms of the pricing of medicines and etc. and all of those things. We've been fighting them. The Cancer Alliance is an overarching body of nearly we are now more than 30 organizations that work within the cancer space, whether it be awareness, whether it be direct patient support or patient navigation, or even palliative care. And we've got seven independent advocates that are associated with us. And our focus is equitable and affordable cancer care for all South Africans. And that's what we are working towards. So we come together, the different organizations, each having their own focus, but as the collective, we come together to fight as one voice. And that's what we do.
Thank you, Salome. Thank you. You're a diamond among all the humans. We need a people like you advocating the true, people who don't have the voices. You are really true advocacy. That is. Thank you so much for joining with me. I'm always honored and privileged to have you on my podcast. Thank you so much.
My pleasure. Stay well.
Thank
To
you.
everybody. Thank you. Thank you.
Thank you all. Good night.
Good night.
Are retailing their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine. Through our unique campaign